Hello and welcome to this Introduction to Infection video. I'm Dr. Aled Roberts, and in this video we're going to look at tuberculosis, more commonly abbreviated to TB, as an example of a lower respiratory tract infection. Now, this particular disease is caused by Mycobacterium tuberculosis, which is an acid-fast bacterium with a lipid-rich cell wall that doesn't interact well with the gram stain. Now, infection occurs when small aerosolized droplets are created from an infected host, coughing or speaking. Now, due to the small particle size created, these droplets enter the lower respiratory tract via airborne transmission and become deposited within the alveoli of the lungs. Now, the infective dose is as low as 10 cells depending on the host, and the incubation period is highly variable from weeks to months, and this is linked to the slow-growing nature of Mycobacterium tuberculosis. Now, unlike some other respiratory pathogens, Mycobacterium tuberculosis does not remain within the airway epithelium. Instead, it survives and replicates within macrophages that try to clear the bacteria away. Now, this is clever as it allows the bacteria to hide whilst sustaining inflammation, recruiting more macrophages to the area which also become infected. And this appears on X-rays as a whitish area, as we can see in the top left of the X-ray here. But how does all of this occur? Well, within the alveoli of the lungs, we have alveolar macrophages, and during tuberculosis, they phagocytose Mycobacterium tuberculosis cells. Now, they don't actually die. Their acid-fast cell wall allows them to grow and persist, triggering a local immune response which recruits various other immune cells. Now, over time, these immune cells organize into a structured lesion known as a tuberculosis granuloma, commonly referred to as a tubercle. And at the center of this are the infected and activated macrophages, including multinucleated giant cells. Now, these are often surrounded by dead cells, lipid-rich debris, and deposited calcium salts, forming a sort of necrotic core. Then, that is enclosed by T lymphocytes, which sustain immune activation and contain the infection. Then, in the more mature tubercles, there is another containment layer of fibroblasts. Now, the main pathological feature of TB infection is granulomatous inflammation of the alveoli by the tubercle. This is essentially tissue damage caused by sustained inflammation and the production of reactive oxygen species, reactive nitrogen species, and proteolytic enzymes, all of which damage the surrounding lung tissue. Then, as the disease progresses, the tubercle can undergo what we call caseous necrosis, where dead cells within the tubercle liquefy, and this drains into the airway. This forms cavities, which alters the lung structure, reduces gas exchange, and supports the growth of bacterial cells, allowing dissemination throughout the lower respiratory tract. Now, one of the key aspects of this disease is that it is what we would call an immune-mediated disease. I haven't talked about any toxins up to this point, and that is because they aren't required for infection and disease. The disease arises from how Mycobacterium tuberculosis interacts with the immune system, triggering that continual inflammation while cells hide within the macrophages, and it's that inflammation that causes cell damage. Now, one key aspect of tuberculosis is that it has 3 stages of infection, which kind of separate out tuberculosis infection from tuberculosis disease. And so following exposure to Mycobacterium tuberculosis, only about 30% will go on to develop primary tuberculosis infection. So we get tubercle formation in the alveoli, and there are 2 options at this point. The most common option, occurring in 90% of cases, is a progression to a latent TB infection, where the immune system arrests the progression of the infection. Bacteria are contained within the tubercle, and there is no symptoms or transmissible disease. The second option, which only occurs in 10% of cases, is a progression to a primary active TB infection. This is where the initial infection progresses directly to a symptomatic clinically active disease due to the failure of the immune system to contain the initial infection. Now, in addition to primary active TB infections, we also get secondary active TB infections where the dormant bacteria reactivate later in life, leading to active disease, typically with lung cavitation and high transmissibility occurring 3 months after this activation event. Okay, so how do we go about treating tuberculosis? Well, it's a little more tricky than some other infections. We are able to use antibiotics, however, due to the location of the bacteria within the tubercle and their specialized cell wall, they need prolonged treatment, usually in the region of 2 to 6 months due to the slow-growing nature of the bacteria. Now, we typically used specialized antibiotics for treatment such as isoniazid, which specifically inhibits the mycolic acid synthesis, stopping the formation of the mycobacterial cell wall, as well as some more common antibiotics such as rifampicin to stop DNA-dependent RNA polymerase. Now, if multi-drug resistant strains are identified, then the outlook isn't great. Typically, patients will be prescribed a cocktail of antibiotics, including various fluoroquinolones, kanamycin, which targets protein synthesis, and bedaquiline, which targets mycobacterial ATP synthase. Now, one of the more interesting aspects of MDR tuberculosis is that the World Health Organization's treatment strategy requires direct observation treatment, meaning treatment compliance isn't in the hand of the patient. The antibiotics are administered by a healthcare worker to ensure compliance. Now, unfortunately, there are some instances of extensively drug-resistant tuberculosis, and in these instances, bespoke antibiotic cocktails are prescribed. Now, we do actually have some preventative measures in the form of vaccinations. Now, unlike some other vaccines, the tuberculosis vaccine uses the Bacille-Calmette-Guerin or BCG vaccine, which contains a different mycobacterium in the form of Mycobacterium bovis, which is a weakened strain but still capable of raising an appropriate immune response. Now, the use of this vaccine isn't common in first world countries anymore, where it has limited effectiveness in children and is essentially ineffective in adults. Instead, it is commonly used in parts of the world where the disease causes significant morbidity and mortality. And with that, we come to the end of this video. I hope you found the content useful, informative, and most importantly, easy to understand. Thanks for watching, and I hope you have a great day.